Hello and welcome as you are coming in. Hi, my name is Jada Shapiro, founder of Boober, and I'm here today with Lea Rivera, IBCLC, and we're going to talk more about both of us. But while we're waiting for everybody to come in, would love for you to drop into the chat. Let us know who you are, what's going on, how many weeks pregnant are you, or do you have a baby, and where do you live? Or are you possibly a birth or lactation professional? Let us know. Just drop that into the chat. It's nice to see who we have here. And then we also, I just have a little poll, which I realized, so if you could fill that out while we're waiting, we'll just let a couple more people come on in. And if you are not represented on this chart because you're not pregnant or postpartum, I'm realizing that question isn't on here, the answer. Let's see. Always realizing things that didn't quite make it in there. And as people are still entering, let us know, drop into the chat because that helps us know who's here and that you can hear me. Great, so we have somebody who's trying to conceive and a lactation educator in California. Welcome. Anybody else want to share with us where you are coming from? It is always fun to see who's in the group. Hi, we got a CLC in New York. We have another CLC from New York. Charlotte CLC, so we have lots of professionals here today who are interested in learning. We have somebody who's 35 weeks in LA. Welcome. I'm from LA, but we are in the New York area. We have a new mom in New York. Welcome. Thank you so much for coming today. And as people, we have somebody in Chicago with a 2-month-old with a tongue tie diagnosis, which was clipped. Okay, so we have lots of different experiences here today. Thank you so much. Just seeing a couple more people coming in, and they'll get started in just a moment. We have somebody who's a new mom with a posterior tongue tie baby in Brooklyn, and we will break that down. We have lots of people in many different experiences. All right, so I am going to, and we have a postpartum doula and CBC who took the CBC class. All right, so let's get started. So welcome everybody. My name is Jada Shapiro. I'm the founder of Boober. Boober is a platform where expectant parents and new families can find all of their pregnancy to postpartum care providers like birth doulas, postpartum doulas, lactation consultants, and mental health therapists who specialize in pregnancy to postpartum. I started Boober, really grew out of my first company, Birthday Presence, which provides childbirth education, classes, lactation education, newborn care, CPR, and we run doula trainings and what I love, we run twice a year with Lea Rivera, IBCLC, who is here, her very own certified breastfeeding counselor course, which she created. And so I'm very excited to have Lea here. I'm going to read a little intro about Lea, and then we'll let her kind of take over that. And I also wanted to thank Teton Cossett, who's doing a little giveaway with us today of some nursing wear. So we're going to be discussing all things kind of related to tongue tie, including what it actually is, how a tongue tie can affect nursing and bottle feeding, how it's diagnosed, when and how it can be treated, why there's so much conflicting information among pediatricians, parents, lactation professionals, how to seek care for parents who might be struggling, just so much in there, right, to talk about. So I want to tell you about Lea, and then Lea will say hi, and then we'll get going. So Lea Rivera is a DONA-trained birth doula, international board certified lactation consultant who holds a master's plus 30 in educational psychology and has been working in the field since 2008. Her mission is to empower parenthood through supporting educated and collaborative decision making in the care and feeding of infants. As a maternal child health educator, trainer, and practitioner, she has served the tri-state area for the past decade and more, providing lactation and birth doula care to countless families. She's the owner of Empire Lactation, through which she developed a copyrighted curriculum for certified breastfeeding counselor certification, which has included trainees who are IBCLC clinicians, birth and postpartum doulas, labor and delivery nurses, family medicine physician assistants, as well as obstetricians and pediatric residents. So we're very excited. That training starts on September 30th. So join us if you'd like. And Lea, tell us a little bit about yourself, if you would, and your career and how you got into this work and why you know so much about tongues.
Oh, that's a loaded question. I will try and keep it clean. I got into this business totally accidentally, and it was basically when I was 8 months pregnant with my second. I realized that the career path I was on was not going to be conducive to raising a family, and I did what every sane 8-month pregnant person does, which is submit their resume for evaluation, because that's normal. And then I ended up getting a job that led to doing research over at a hospital in New York City. And that led to me getting my IBCLC. And 13 years later, here I am. Currently back in school for myself, doing prereqs towards my physician assistant's degree and managing my 8th graders' schoolwork and my other undergraduate schoolwork. And you know, everything that the full-time working mom in COVID does. So, and within all my learning, I learned a lot about tongue tie. It actually is something that just sort of sparked the radar of lactation consultants in about the time that I entered the field. It really wasn't discussed before that. And over the last 12 to 13 years, we've seen a lot of information come up around it, some research, some anecdotal, but it really has become sort of both the catch-all and the well that many of my clients certainly come into and are concerned about. So when you asked if there were people interested in talking about the topic, I was like, absolutely, happy to do so.
Thank you. So we're so glad you could join us for this because it's really such a hot button topic right now. I mean, certainly, you know, so many of the parents who are coming to Boober, other lactation professionals, are reaching out with potential symptoms or signs of tongue tie, or maybe receive this diagnosis or are thinking they might have something like a tongue tie. Ultimately, they're having issues with feeding. They don't come to us because when they're not having issues, right?
It's true. I don't ever see, occasionally I see someone who goes, I really just wanted you to check and see if everything was great. And I'm like, I love that, but yeah. Okay. Yeah. No, so, my sample's always biased.
Totally. Like all of our samples are biased. Everybody who's coming to us is struggling in some way. Otherwise, yes, they're doing okay. And plenty of babies do just latch on and feed, and we never have to talk about that at all. That's happens. Correct. But then there's this subset of parents who are going through something that can be really challenging, especially when there's so much differing opinions or questions, or does this exist or not? So I kind of wanted to really simplify this, as this is the first in our series that I'm excited to be doing. But can you just explain to us what is tongue tie? What is the actual medical term? What is the simple way to explain it to people?
Okay, so tongue tie medically is called ankyloglossia, which is a tethered tongue, right? So it's the idea that your tongue should be able to move freely in your mouth. So most of us who are not tied are able to use the tip of our tongue to clean the top of our teeth, get all the way around. And even when we sleep, our tongue is actually cleaning our teeth, okay? And with a person who has a tethered tongue or tethered oral tissue, that tongue is no longer able to do all of those little movements. So what we frequently see is a lot, especially as they get older, we'll see a lot of dental caries or cavities in the back of the mouth. We'll sometimes see cavities forming on the front two lower center teeth, so in the lower jaw and the center, those two. And that's all because the tongue is not moving the way it's supposed to. So it's not functioning the way it was designed. What we also see as children get older is usually a feeding preference, or sometimes that'll come up as well, because the tongue it's sort of like the first part of our digestive system, right? And it smashes food up against our upper palate, allowing us to successfully chew and swallow. I had a client several years ago where the child was identified with a tie, and as I'm describing to the parents, the mother's eyes pop open and she says, oh, I think I have one too. And I was like, but why? And she says, I can't eat sandwiches. And I said, sandwiches? And she said, yes, you know, like those really nice ones that everyone likes to eat. She couldn't open her mouth well enough or use her tongue well enough to smash the sandwich into bits in order to chew and swallow. She'd always take little bits off or cut little pieces off and actually use her fingers and her silverware in a way that her mouth and tongue was supposed to.
Ah.
So the tongue tie really does have a lot of implications, but fundamentally it means that the tongue is not functioning the way it was designed. And we identify that with a short frenulum. Some practitioners will call it a short tongue. In fact, if you translate tongue tie into Spanish, it often is translated directly as short tongue. Although that's not at all correct, but it is often how it is described. So what it looks like is most people who are tied cannot extend their tongue much past their gum line with their mouth open. Exactly, which is pretty much how I spend 3/4 of my life is explaining this to people, right? So when you cannot extend your tongue past your gum line, it is usually because the frenulum, the little tissue underneath, right? That little tissue underneath is shorter and or connected more closely to the gum line than would be typical in a fully functioning mobile tongue. So that's graphically or what a tongue tie is.
Thank you. So, what are the most common symptoms of a tongue tie? I mean, how does it can present itself in so many different ways. So it'd be helpful if you could kind of share, first on the level of like when parents start to realize something's not right. What is it that they're experiencing, would you say?
When we're talking about a lactating parent, what we're really seeing is that birth parent saying, my nipples really hurt. That nipple pain is usually the first symptom. From nipple pain, we usually move to nipple damage, some type of abrasion, cracking, bleeding. And it's something I tell my clients frequently, and particularly my birth clients, that nipple soreness when you first start feeding your baby is normal, right? You've never stuck your nipples into a vacuum cleaner 10 times a day. So the tissue adjustment is normal. But you should never have cracking or bleeding. And if we're cracking and bleeding, then something is wrong. Typically, what we call that is a shallow latch. And that's where the IBCLC comes in and says, well, is it a shallow latch because we're learning a new skill, right? And we don't quite know how to latch our baby on? Or is it a shallow latch because the baby is unable to make a deeper, more effective latch? And that's that's the start of the diagnostic process, really.
Right. Yeah, it's interesting, right? Because so many people come to believe that cracked, bleeding nipples are just normal, that we should accept that as part of nursing.
Right, and it's not. As I said, tender, sore, sunburny feeling is how I describe it, right? That is normal. It is a muscle, or our nipples are muscles. They will stretch. The tissue is new. It's being used in a new way. And just like when we were finally allowed to go back to the gym and all of us went, yay, workout, ow. Our nipples kind of have the same feeling. But they should not ever really crack and bleed. And if they are cracking and bleeding, it's one of the first signs that that person should reach out to someone to support them in skill building and learning.
Yeah. So if someone reaches out and, what is the first step when you're working with a parent who is experiencing some of these issues where the baby can't get that deep latch, or they're having a lot of the cracked, abraded nipples, et cetera? What are you looking for? How do you work with them when you look at the tongue of the baby? How does that work?
So I do a full oral assessment, and what that looks like is with gloved hands, like holding the baby's chin down and their mouth open gently, and really looking at the mobility of the tongue. So I'm looking at things like lateralization. How does the baby move their tongue sideways? Exactly. Can they lift their tongue up? Okay. Now, obviously, they don't have teeth, so, you know, we do the best we can. Can they, with their mouth open, extend past the gum line? Those are some of the key criteria I use. I also will often do a suck assessment, which is where I will have the baby suck on my finger, sometimes with food, which is basically finger feeding, sometimes without food. It depends on the child a little bit. And that suck assessment tells me, as the child is trying to eat, how are they moving their tongue? Are they cupping up and around the finger, which is, which of course only a certain percentage of the population can do. Are they cupping? As they go to swallow, are they maintaining pressure or are they losing pressure? Because if they're losing pressure, it's something that lactation consultants call piston, or we're pistoning the jaw. And that's much more of a chewing behavior. We shouldn't see chewing on the breast. When I talk to people and they say, well, it feels like my baby's biting me, that's almost always a clue to me that I need to get inside that mouth and see what's going on, because no baby should be biting at the breast, right? So those are the things that the sort of things that I'll do in an initial assessment or evaluation as to what's going on.
And would you say that it's possible, let's say you might see something that looks like the tether oral tissue or the frenulum is tight, you know, you're looking, but how often would you see the presentation of the tongue in that form, but have the parent not having a lot of issues with feeding? So for instance, you know, somebody actually reached out to us and said, well, they saw a potential tongue tie at the hospital, which actually is the reverse of the story I would usually hear. So somebody told her that the baby seemed to have a tie, but this person is not having any feeding issues thus far. So they're kind of wondering, well, what do I do? So I guess if you could speak to how often would you see that, but it's actually fine.
So yeah, and this is where we start to get into the complications, right? Yeah. Because nothing is ever straightforward. We have the science and then we have the art and magic. We also have to, when we look at tongue tie, when we look at presentation of tongue tie, we should also be looking at the structure of the baby itself. So, for example, a baby who who's delivered after a prolonged induction, whose birth parent has pushed for 3 or 4 hours, that baby's going to have a lot of molding and cranial asymmetries resulting from birth process. Those cranial asymmetries can mimic tongue tie and often are very evident in the hospital. As the baby's head molds back into the cute little softball shape that we're expecting, the presentation of that tie may seem to disappear because it really wasn't a tie. It was really a result of the birthing process. On the other side, some ties, certainly more classic, what people would consider anterior ties, would never disappear. And that's where we look at what is the function? How is this tongue moving around? Because just because it's tied doesn't mean it doesn't move at all. Also, it's a muscle. It's a muscle that's being responsive to feeding input, which is one of our like high drive behaviors. So we want to eat, we want to nurse, we want to do this, and the baby will do everything they can to try and do it. And then we have the third, what I kind of call my third circle of the Venn diagram, which is the birth parent themselves. If they may have just come into lactation as a happy lactator, like they just are making enough milk for their child, the child down the hall, and the 3 children in the next neighborhood over. That's a very different experience than the person who may also be struggling with their milk supply. So pain is not the definitive diagnosis criteria for tongue tie. It really is about the function of the tongue and the mobility. I mean, my second child was tied, and I knew it from the gate because his grandfather was, my father, and I didn't have any pain. but he was also my second child. I'd nursed for 4 years. Turning tassels off my nipples was a thing. I mean, you know, and he was a big kid. I fed him you know, it all matched together, so we didn't do anything until he was 12. So there's pain, as I said, is not the definitive criteria. It really is the function of the tongue and a variety, you know, and then we get into shades of difficulties or gray.
Right. So, you know, pain, and then we're talking milk supply a little bit. So could you address that a little bit, right? Because some people seem to really, as you said, have an abundant milk supply initially, but often my understanding is that as we get closer, sometimes around the 6-week mark or further, and if you could explain that system shift where there might be then a decrease in milk supply, could you explain a little bit of that for the people who are kind of all of a sudden at 2 months going, wait, what happened?
So in the early part of milk production, it's very hormonally driven, right? The body says we were pregnant, we have delivered our baby, we've delivered our placenta, we are going to make milk. And that hormonal drive can really keep us going for nearly 8 weeks. At and around 8 weeks, it starts to shift to supply and demand. The baby has to be removing milk, or I have to be using a pump to remove milk. Otherwise, the body says, why am I spending all of this energy doing this thing that you don't seem to be using? You know, overall, our anatomy, our human bodies are designed to keep a very low energy level, right? We're not going to spend energy unless we need to. This holds very true for the milk production process, in the sense that by 8 weeks, if we haven't really been using this milk effectively or consistently, the body will just start to shift it off because it doesn't want to spend the energy. What happens in the initial stage is if we have a baby who is tied and not being super effective, then what we will get is a child who is living on letdowns. So basically the parent loves the child, right? There's oxytocin, there's a letdown, there's all this stuff going on, but the baby's not generating that flow. The parent's just sort of pouring milk into them. And that's where we start to see those wobbles at 1 month to 2 months in weight gain, where we start to see decreases in milk production.
Okay. Thank you. So it seems, would you say, I guess, that what we hear, at least from many pediatricians, there's a feeling among the world right now that all of a sudden tongue tie is being diagnosed so frequently and it's so prevalent. And I think that I would just love to hear your perspective on what's going on. Are we just better at diagnosing? Is there something going on culturally? What is there a genetic component? Could you just talk a little bit, because this topic is so fraught, and I think so hard for parents who are struggling, who then might have a doctor who says, no, there's no such thing, it doesn't exist. And that is not true at all of all pediatricians, but we definitely have some people who are struggling with that, who feel like, well, I was told that my baby doesn't have one, and I was told that my baby does have one, but ultimately I don't know or not, but I'm still just not feeding the baby well. It hurts, it's not working. So it's still like, are we seeing it a lot more? Is that true?
That's one of those fraught questions, right? The answer is A and B, definitely, with a good dose of C.
Cool.
A, are we seeing more of it? Well, yes, we're seeing more of it because we have gotten better at diagnosing or identifying tongue tie. It's become a thing. And so anytime we become better at doing something, we see more of it. That's just the nature of human medicine and science. Is there something societal? Yes, there is something societal. Basically, in the last 3 years, we have reached a place where 80%, slightly over 80%, of American birthing persons are initiating breastfeeding. That is probably, and I won't let you quote me on this one, Jada, But it is really close to probably the highest level of breastfeeding initiation since pre-World War II. Okay, if we look at World War II as being sort of a shift in society where women started working out of the home consistently and in larger numbers, that would also tie into where formula became a little bit more ubiquitous. With more breastfeeding, we have more breast pain. With more breast pain, we have more, what's going on, help me. And so we definitely, you know, if there's those, that's the A and B. Yes, we're getting better at seeing it. Yes, society, we just have a bigger pool to work with. Is there a genetic component? Yes, there seems to be a genetic component to it. And we can I'll kind of put that over on the side for a minute, because I do see in our little chat here, someone's asking about what's the earliest I might have ever identified a posterior tongue tie. And the answer is probably 1 to 2 days old. You know, with the understanding that there were other things going on, but yeah, that looks like what it should be. And is it fair to base all on just one visit or one oral assessment? This is one of those really, you know, most lactation consultants don't take insurance for a variety of reasons. For those who do and are able to see their clients more than once, I think multiple assessments are really, really helpful, because babies change over time, right? I mean, we see the head molding change, we see the weight gains, we see parent confidence change over time. So all of those things are really valuable. But it's also why lactation consultants take such lengthy intakes. My intake form is, I believe, 44 questions long. I've had complaints like, we can't know all this out. I'm like, just do the best you can, because that information is critical. It really, like, every little piece gives me a piece to the puzzle. So I don't know if I would characterize it as fair or not, but, you know, we're not the cheapest people in the world. And, you know, I certainly hope my plumber would be able to come in and assess and diagnose my, you know, plumbing issue in one visit, but maybe it takes two. So it really depends.
Yeah. Yeah, and this person is asking, right, IBCLCs can't diagnose a tongue tie, right? Would it be the child's pediatrician to make the official diagnosis, or other healthcare provider? So this is actually a great kind of segue question. I mean, we want to answer that, and we also want to talk about, you know, who are then the different people who do the assessment, diagnosis, and let's shift that into, and then how do we, of course, treat or deal, or, you know, so let's break that down a little bit. So can you diagnose?
Okay. Can I diagnose? Well, one would argue, what is diagnosis? An IBCLC is considered an allied healthcare professional. And so on one level, there is diagnostic criteria that I can fulfill. That being said, so for those in the group who are CLCs, CBCs, and other professionals who are trying to wrap their head about where their scope of practice is, you are being often asked for what's called a super bill, right? So you're being asked for something that insurance will reimburse for. On that super bill, you have to put an ICD-10 code, which is a diagnostic code. If you are using a diagnostic code, if you are providing a super bill, then you de facto have made a diagnosis. This is where it gets tricky, though, because I will never, ever submit a super bill. I will never give a client a super bill that says that I have diagnosed a tongue tie. I will only identify that there was a lactation-specific disorder of the lactating person, Z3, 9 point, whatever, you know, ICD-10 code, right? I never, ever put down the presentation of tongue tie as the diagnosis. And the reason I don't do that is because ENTs, pediatric dentists, pediatricians are the proper professional to make the official diagnosis. They're the ones, given whatever American insurance you're dealing with, who have to then make those referrals if referrals are necessary. Okay, so they are the ones who do make the final diagnosis. I can only and support my clients in identifying that which I am seeing based upon symptomology, and then encourage them to speak with the professionals who will make the final diagnosis.
Thank you. And can we actually, let's discuss a couple of those people, right, who you would refer to. You mentioned, and just so that there are a lot of parents here who might not know or be thinking about it, right, between the pediatric dentist, the ENT. Can you talk a little bit about that? Who are the people in your neighborhood that you would go to here?
So typically if an IBCLC feels that a tongue tie is impacting the nursing relationship, then what we do is refer to both the pediatrician and also to either an ear, nose, and throat doctor or a pediatric dentist who has demonstrated skills in revision of tongue tie or revision of the restricted frenulum. So those are sort of the people in my neighborhood, right? IBCLCs should be in general, and CLC should be as well, providing a care plan back to their client. Part of the IBCLC's code of ethics is to continue to communicate with the pediatrician and other care providers in that family's circle. So a copy of my care plan does tend to get faxed to doctors when I deem it a necessity or within the interest of both parties. So ENTs have traditionally been the people we referred to. Pediatric dentists kind of have come in the last 5 to 7 years, I think. And right now, it's not so much who you go to as to the skills of the person you go to. You can go to either one.
Mm-hmm. And, one of the questions actually we had, some parents people submit questions earlier. So this kind of leads into, people had a question about, so frenectomies, can you explain what that is? And what are the downsides of doing that? Does it work? Does it not work? This is a big question, I know.
Oh,
it's a huge question.
Okay, how about we put that to tongue tie 2?
That's true, we
okay,
could.
I'll try
but you could at least explain frenectomy.
I will try and bring it into some framework here. So a frenectomy or revision is the releasing of the frenulum in order to improve function of the tongue. It is done in one of 2 ways, and the first one, which is the most common or popular up to the last 7 years, has been a scissor revision, and basically it's either small little scissors or a scalpel that just clips the tissue underneath and releases the tongue. It really is, at least in my experience with my clients, far more traumatizing to the parents than it is to the child. The child is already righteously ticked off at us when we have swaddled them and start to hold their mouth open. They're just like, I'm going to scream at you no matter what. By the time the procedure is done, it really is as quick as receiving a vaccination. The child squawks, the wound is packed with a little bit of cotton wadding, and the bleeding subsides very quickly. I analogize it to like biting your lip. If you bite your lip, it looks like a bloody murder scene, but if you remember to stop biting your lip, it heals really quickly and you've forgotten all about it, okay? So that would be a scissor or scalpel revision. The second version is with laser. It's usually a carbon dioxide cold laser, which immediately cauterizes the site. So there's no blood associated with it. There can be a little bit more swelling of the tissue of the tongue, but again, it's a very quick procedure. Oftentimes the setup for the procedure takes far longer than the procedure itself. The healing time in both cases is about the same. It's about 5 to 10 days for the wound itself to heal. Depending on provider, we are moving into a place where some exercises and relearning and retraining of the tongue are deemed to be useful. In fact, there was a research article just published early this month, that looked at a revision of an adult male, and that post-revision, it was encouraged that he go to speech-language therapy to relearn how to pronounce and use his tongue properly. And we do that with infants using either SLPs or occupational therapists, where we do some stretching, where we are teaching some sucking exercises and really strengthening the muscle of the tongue. And I'll say as a mother, I did that with my son at the age of 12, because functionally, once he was released, he actually could not figure out how to touch his top lip with his tongue. It took him over a week to learn how to do that.
Wow.
So there are definitely things, so it's a good procedure. I will say in my practice, for the people I referred for revision, at least I'd say 80 to 90% of them have have significantly improved breastfeeding relationships. But there are some areas where maybe it's not the best recommendation.
Well, thank you. I think that clarified a lot. I mean, can you explain a little bit what are some of the potential, let's say we do nothing and the feeding is not totally functionally compromised, or maybe the parent has decided to do some pumping additionally, and maybe some bottle feeding, although we know when there's a real situation, certain tongue tie can compromise the ability to bottle feed as well, right? But can you explain a little bit of parents really, I have a couple questions here asking about what are the particular speech, feeding, solids, sleep issues that can come down the road if we don't assess if we don't fix the tie?
So again, it kind of depends on where we are in the function and assessment phase. Let me start with the most critical. So if we have a really severe posterior tie that's pushed the upper palate up, we are impacting on the sinus cavity in the upper cranium, so the upper head part of the skull. When we impact the sinus cavity, we may be causing issues along, breathing, apnea, snoring. There could be immunological variations as well. I mean, our sinus cavity is there to protect as well as to breathe. So that's something to think about. When our upper palate is severely arched, we also tend to have a narrowing of the upper jaw, which would create crowded dentition or teeth coming in, overlapping each other. In certainly my generation, we didn't really have really good palate expanders. So a lot of people in my generation got their teeth pulled. Mm-hmm. And that gave them enough space to have proper dentition by whatever orthodontic standards. Now we have better palate expanders and things like that. But what they're doing is compensating for the really severe tongue tie. If the tongue tie is not released, if you go into the orthodontic research, if the tie is not released and they're trying to do a palate expansion, as soon as they stop applying the pressure, it goes back. So you could spend a lot of money on orthodontics that ends up not working. So that's the most severe case. In sort of the middle ground, we might have some feeding issues. We may have reflux issues because, again, our tongue is the first part of our digestive system. And if it's not able to do its job, then the other parts of our digestive system have to compensate. So we can see reflux, we can see food aversions and things like that. And continuing down to sort of the least of the concerns or long-term concerns would be speech impediments, such as if you're a classically anterior tied person, which means the tip of your tongue does not stick out past your gum line, it may curl over. That will prevent you from forming certain tongue tapping letters like T's. D's. T's and D's may end up sounding very much the same. R's because you need to roll from the side of your tongue to the front of your tongue can be very difficult. Any Romance language that has a roll sound to it, so anything in Spanish like double R, very difficult to pronounce. Certain languages like Japanese, Korean, where there's not so much tongue tapping, you may not get the same speech impediments, but there may be differences there as well. So the variations are linguistic and have to be looked at from certain different perspectives, but that would be another area of concern. And so there, you know, aside from just the breastfeeding, of course, right? So we want to look and say, be able to identify what the possible sequelae or continuations or consequences are to this type of tie that we're seeing.
Okay. And it's interesting as people are kind of deciding, because I guess, again, they're making decisions based on how much the feeding experience is being impact their nursing experience in the first place, right? So I think with somebody who's having less impact, but has that diagnosis, may be wondering, well, is this going to be a problem down the road or not, right? But potentially, I mean, you told us that you dealt with this in your son at age 12. So one could do this at any point along the road if they felt need. Sure.
Absolutely. And in fact, there are lots of adults who have done revisions of themselves, you know, who've had revisions undertaken, you know, at the, you know, in their 30s and 40s and 50s. And all of those are, and for the people that I personally know who've done that, have found it to be advantageous. You know, it's hard as a parent to make the decision that you were going to do this thing to your child with a what if on the other side. Will this make it better? Is this important enough to do? The conversations I've had around this, in fact, very recently with clients, is sort of like around body agency and autonomy. But we also make a lot of decisions for our children, you know, early on that we may have to, you know, we may think whether those are totally right thing to do, or you got to do an ooh.
Yeah.
And this is a hard one. It really is. If you're in that situation where the tie is not directly impacting breastfeeding at this minute, making those decisions can be difficult. But I think the research is starting to show us pretty clearly that it's better to do it earlier than later because of the potential impact. It's not, the downsides of the revision are really small. I mean, the risk to infection is very small. The risk of excessive bleeding is very small. We're not going to take a tongue that's been maybe slightly tied, which is a way that pediatricians will describe it, and suddenly turn the child into Gene Simmons. You know, they're just not going to have that crazy tongue to the top of their nose behavior. They're just going to have a little bit more mobility than they had previously.
Yeah. Well, on that note, while we're thinking about these alternatives, I know that there's a lot of different body work options as well that many lactation consultants suggest maybe to try before or in conjunction with a revision, such as craniosacral therapy, chiropractic therapy. Can you explain a little bit about how that would work in the first place? Why would that be impactful? And is it possible to do that kind of less invasive work? Might that actually mean you don't need to do a revision? And how does that work?
So the idea is, let's see if I can sit sideways. So here's my lower jaw, comes in at our temporomandibular joint, which is right by sort of our earlobes, right? And connects into our upper jaw. There are about 3 different muscles that come down along this temporomandibular joint. And there are more muscles underneath my jaw that are connected right with my tongue, so sort of in this positioning. Between my tongue, the muscles of my lower jaw, the muscles of the side of my jaw, we also have this large muscle along the side of our neck. Roughly 6 different muscles right there. All of those are impacted by the tightness of the frenulum. If you think of it as like if we have, this is, you know, me pulling on my frenulum and I just need to follow it, right? The fabric, the skin, the muscle, everything is going to follow that pull, okay? And with that tension can come displacement of the atlas or the very top cervical vertebra. There can be temporomandibular joint pain. You know, so there's a bunch of things that can be going on. When we have any type of structural changes, that's where we look at alternative physical therapies like craniosacral and chiropractics to help bring those bones back into place so that as the muscles release, they can actually start regaining their proper motor function. That's how it ties in. There's also oral rehabilitation, there's occupational therapy. I mean, there are a lot of other modalities that we can use, and there are certainly quite a few care providers that are starting to become cross-trained in that way. So that, because we see the cause and effect. We see where, you know, and we as adults who may not be tied do recognize, like, if I sleep funny and my neck gets crooked, the whole rest of my day, my shoulder starts to hurt, my neck hurts, I don't want to eat the big sandwich today because my neck hurts. So there is that type of patterning that we also need to change. With my clients, to keep it really simple, I describe it as, you know, if you've ever broken a bone and you've had that limb in a cast, 8 weeks later, they take off the cast, they say, you're healed. And you go to, you know, sign your name on the dotted line and you're like, what happened to my hand? Well, the same thing happens with a baby, right? They've never used their tongue that way. We're asking them to use this muscle in a whole new way. And yet they might need some help learning how to do that. And that's where the modalities come in.
So you could do that after, or you know, a lactation consultant as well, you would do aftercare exercises potentially if they were seeing you again, right? Or if
absolutely. Absolutely. I mean, with my clients, I always, if they see me first and then go for revision, if they can see me again, I like to see them again. If it's a financial challenge for them to see me a second time, then we do this type of, you know, Zoom chat, and we talk all the time about different links and different videos and different ways of assessing and moving the child forward.
And actually, speaking of that, the Zooming, somebody did ask if you could just speak to, are you able to make these tongue assessments virtually, which I have seen people. I would love to hear if you've been doing virtual assessments. And
I have. I'm also really grateful that I've taken a variety of precautions to be able to see people in person again. Anyone who works in this field understands the oxytocin hit that we all were missing for months. It is a wild and crazy drug. So I'm grateful to be able to see clients again in person. Assessing virtually is, in my opinion, not ideal. Is it possible? Yes. Usually if I think based upon my intake that this is something that I need to know more about, then I usually will send my client a picture series. Dr. Kotlow up in Albany has some really good pictures available online that look at different ways of assessing, as well as what different ties look like. And so I will talk my clients through the process of doing what we have all come to call the Kotlow maneuver. And if they can then either be online with me, and, you know, if they have a partner or a family member who can hold the computer or the phone in different directions, I can then say, yes, this is what I'm seeing. Or if they are, let me see if I can close my dogs off. There you go. All right, so back. Or I will have them take pictures and send me variety of, you know, just different angles, different pictures of the baby in different positions, of the mouth in different positions. The baby can be in all sorts of places.
Thank you. So, okay, as we wind into our last 10 minutes, we have a couple other questions I want to get to that people submitted. I also want to invite everybody, I'm going to type it again, but Lea is at Empire Lactation. She's also teaching with us at Birthday Presents, our sister company, shortly. You can also follow us on Instagram at, if you don't mind grabbing out your phone, at Get Boober. And Lea, you're at Empire Lactation, right?
Yep.
So you can follow us both there. We do lots of different teaching tips on Instagram, and lactation, birth, postpartum, life, maybe. So visit us there as well. And so I wanted to ask the question, somebody asked, is there any, if I'm having nipple pain, managing it with a tongue tie, is there any worry about using a nipple shield for too long? So I'm not sure if this person chose to use that or if they're working with somebody, but could you just address a little bit about pain, nipple shields, tongue tie relation?
Nipple shields are badly named. They don't actually hide the pain. A bad latch is a bad latch is a bad latch. If the parent has received some relief from the pain with the nipple shield and the baby is eating effectively with the shield, that's a really key and part. If the baby is eating effectively and the parent has regained some relief, then we can usually wean the parent and child off the shield over time. I have not found in my practice that the nipple shield is overly helpful when it comes to ties, because yes, it may dull the pain, but it actually may encourage the baby to chew more. And if the baby's chewing more, they really are not effectively nursing, which will then quickly get us into a cycle of bottle top off. The bottle top off turns into 2 ounces. The 2 ounces is now the meal, and the breast is just this fun toy. So as much as we can, we want to identify the root cause and fix that. And if the shield is something that can be sort of used as training wheels to get us to a goal, that's great.
Thank you. Somebody here had an ENT clip the tongue tie, has not had improvement with breastfeeding, even with 2 lactation consultant visits after the clipping. It's not a supply issue. We've been feeding her pumped breast milk in a bottle. Do you have any suggestions for next steps?
I would question what ENT or which ENT did the procedure, whether it was a full clip or not, because we do sometimes see partial revisions. I would also question, if some body work might be effective or some work with an OT might be helpful in this case. If it was a really severe restriction, babies really do need a lot more support than we think sometimes to get that strength and normalcy of peristaltic or wave-like motion going. So I would look at those 2 things: is who did the initial procedure? Was it done effectively? Or was it just, I don't really know what I'm doing, clip? And if it was an effective procedure, does the baby need just a little bit more OT or physical support in learning how to suck more effectively? In my practice, I would probably teach some finger feeding and some sucking skills so that the baby would have that connection with the parents of eating and practicing and learning. So those might be the 3 pieces of advice I'd give to that person.
All right, thanks. And somebody else here asks, what is an approximate price range visit for a lactation consultant, virtual or in person? So if you want to share, I can give it's a pretty wide, there's a range.
It's a pretty wide range. If you're going with an IBCLC and we live in any major metropolitan area, I would say that the range for virtual, I'm probably on the low side. I do a just-in-time, like, hey, I've got this really major, quick question I've got to ask because I'm pumping right now. I call it my just-in-times, which are $75 for 30 minutes. Whatever you can cram out of me in 30 minutes, you can pay for. to, I think the upside in New York City is right now around 425. So it's, yeah, I mean, virtuals are probably between 140 and 225, 250.
So that's, you know, there's your range there, and it does depend, you know, with the, if it's not a just-in-time visit, like we have those as well through Boober, kind of a shorter visit that, you know, but you really, it's hard, you'll find actually to accomplish much in 30 minutes or 90, you know, or 60 minutes, but you can, or 30 minutes is hard, but sometimes you just have that one question. So, you know, people are out there trying to make it affordable to get to that place for you. And then, you know, other visits don't have time limits on them, just so that you all can understand why there are these larger charges. Often there's not a time frame on it, and they will work with you as long as you need. I mean, not forever, but you know, it could go a couple hours and beyond to really start to parse out what the issues are. And so in a more complex case, it can, you know, it can be there. So yes, that's really cool.
I mean, my stance is to give people an idea, like, why do I charge what I charge, which for most, I range between 275 and 375, kind of depends on how close to my house are you, and or I give a reduction for teachers and first responders and people like that. So why do I charge what I charge? My visits are a minimum of an hour and 15 minutes. Like, that's the fastest I can do anything. From there, I have to write up my notes. I have to usually share back with a doctor. I'm back in contact with you to share the care plan. I'm in contact with you via text, email, and phone call. I recently had someone reach out who's like, I saw you in June. Do you mind still talking to me?
Right.
And I don't typically charge for more than that. So yeah, it's a bit upfront, but it's a lot for a long-term relationship. It's not that much for a long-term relationship.
Yeah, thank you. And thank you. Oh, hi, Regina. I think you reached out to us, so I will be reaching out to you soon, but we have somebody who's a pediatric dentist in CLC here, and thank you for your note. We also, I want to get to one more question by somebody here who has a baby who's 4.5 weeks old, does very long feeds. I guess we didn't mention that as one of the signs. We should talk about that, right? Like, so this person is experiencing 60-minute feeds. And I was told he has a slight tongue and lip tie. It's not a supply issue. I have oversupply, and he's been taking in 3 ounces of feed, gaining weight quickly. That said, would a revision help him feed more efficiently? Would he get there on his own if we don't revise it? Which is kind of a great round out to the end of this. That's a
yes, let's just throw this.
I'm just going to throw something to you.
Okay. I'm leery of answering that to say yes, a revision would help him become more effective in a shorter feed, because with oversupply and he's transferring 3 ounces on a typical feed, it sounds to me like he's pretty effective, but the question is it 3 ounces over the whole hour, or is it 3 ounces in the 8 minutes in the beginning because you're pouring milk into the child and then he's just sort of hanging out for a while, being like, but this is still fun. I really like it. There are too many Venn diagram circles for me to give a good answer or give a clear answer. What I would encourage this parent to do is really do some looking around about what comfort nursing looks like and the difference between nutritive sucking and non-nutritive sucking, and to see where in that hour the baby may have shifted. If the baby hasn't shifted and it truly is nutritively sucking the entire hour, then the answer is yes, a revision may help. If this baby's playing but mama, you ain't going anywhere, so we're just going to sit here for an hour game, which many babies like to do because it's fun and it's comforting, it's warm, and it smells good, then learning about comfort nursing, learning about normal biological behaviors can be also helpful in this case.
Thank you. So yeah, in this case, this might be one of those situations. I think tongue-tie questions are so complex and feeding questions. So we try in these things to give you the quick answer, but you might want to connect with somebody to talk that out further. And also just to comment on where Regina wrote that revisions are common with some ENT releases. occasionally fibrotic tissue forms post-op exercises are not done, we are going to address more of these different techniques in a further series where we can talk a little bit more about the different people and why some people would recommend scissors or laser, or, you know, there's a bit of certainly a debate out there and different opinions on that. So, you know, and I think people would like to hear a little bit more about that. So, you know, I guess for the last, if I could ask you one last question and then we'll head out.
Sure.
Ready to go. Just one last question that somebody had asked, which was, you know, how do I ask the pediatrician to check for tongue tie? Should I be doing that for any reason, or only if I, you know, why would I be doing that? So, sorry, that is not, let me just say what they said, how early should we be asking that question?
The earlier the better. If you, and I always trust my birth parents, like I trust my clients to tell me if they feel like something's wrong, something is probably wrong. I am not going to discount that gut feeling because you have to be feeding this child. I am not there at 3 o'clock in the morning. I am not there for all the feeds of a day. I'm only there for that one. And it may look fine to me, but if that parent is telling me it hurts or it's doing this or this baby hasn't done that, we need to get to the bottom of that. So because of the nature of milk production, I really feel that parents who feel like anything might be off really need to get into their pediatrician, find an IBCLC as soon as possible, ideally within the first 2 weeks of life, so that if there is a problem, we can identify it, we can start turning it around before we get into a low supply problem, and before we get into plugged ducts and mastitis and all the other things that can come along with this stuff.
Well, thank you so much. I know that there's so many more questions, and we could literally talk about this for hours and hours and hours and hours more. So,
oh, absolutely.
You know, and I hope we will. We're going to everybody who's here, we're going to have parents talking, our parents experiencing this, and you're interested in, you know, possibly on one of the panels. You know, we're going to be talking to complementary practitioners. Thank you so much, everybody. We hope to see you again. Visit Lea Rivera at Empire Lactation, and of course you can find us at getboober.com if you need anything at all. We will be sending you a follow-up email with some links and information. So thank you again for coming out. It was wonderful to have you, Lea. Nice to
Thank you. So it's good to see you, Jada, and to shout out to Diane if you're still on there. Good to see you as well. And yes, if the people whose questions we didn't answer, if they want to go to my website, they're welcome to shoot me an email directly from there, and I will try and answer it for them post-webinar.
Awesome. Yes. All right. Well,
all right.
Have
all
a
right,
good
guys.
night, everybody. See you
You
later.
too. Bye.
Bye.